So I want to introduce Dr. Art Rastenhad now. He is our interventional urologic oncologist. We have to share him with the Department of Radiology, but he is one of the first most urologists that are practicing interventional urology, which involves utilizing techniques to treat urologic problems. He's also currently involved in a number of groundbreaking clinical trials, including prostate embolization and using gold nanoparticles, as well as focal therapy. So I'm very pleased to introduce you to Dr. Rastenhad, who will talk to us about imaging for prostate cancer and focal therapy. Thanks, Dr.
Thanks, Dr. Hi, great talk, Dr. Tewari. Jillian, thank you for the introduction. Well, my talk will be slightly different. I'm more of a guy with a lot of pictures too, but I want to do something with those pictures today, and I'm hopefully share with you why imaging and how it's impacting screening for men for prostate cancer, well as the next step of maybe it's going to impact how you're treated in the future. I do have some disclaimers. I do work with one of the companies that helped develop a fusion platform, as well as a company that I work with for focal therapy. This is my favorite slide. I put it up all the time. We've gone digital to digital. A lot of urologists, before we had ultrasound, used to use their finger, a straw, and a needle to try to hit your prostate to do your biopsy. I hope most of you have not experienced that as patients, because that was back in the 1930s. But as a resident, I actually did it in 2000, so not a lot changed. But what's changing now is the impact of imaging on how we approach patients and stratify their risk for having prostate cancer. I'm going to share with you a new study that has level 1B evidence that imaging before biopsy should be done, and I'll explain why. So everyone, if you're a patient that's been screened for prostate cancer, has had an ultrasound of your prostate. If you haven't, I don't know how they did your biopsy, but it typically is used just to guide them to the prostate itself without any specific area. Most urologists don't look for these. If we could turn the lights down a little bit for my lecture, please. Most urologists don't look for those dark spots, which are areas that could be a little bit more suspicious. However, it doesn't usually work that well for us, because 60% of the time it's not cancer. And if you've looked at the data and you understand that prostate cancer is a disease in search of its own validity. Why do I say that? Because the U.S. Preventive Service Task Force gave a reputation against screening. Why did that happen? It happened for a lot of different reasons, but I think a lot of the fault rests with the urologist, because a lot of patients are diagnosed with low-grade, low-volume disease. As you see here, the last statement, prostate cancer is the last solid organ malignancy that's still diagnosed by randomly sampling the gland. I have a partner and a friend of mine and a colleague that helped invent the fusion device I've been working with for years. He was at the AUA about six years ago. He stood up in front of a panel like this and said it's malpractice if your urologist does a non-guided biopsy of your prostate. The AUA quickly grabbed him off the side and said, you can't say that. That was a while ago. I think we're getting to the point where imaging at least should be tried. Not all insurance companies cover it for their patients. That's the difficulty we have with that, but it should at least be tried. And I'm going to show you why and why I think that plays a very important role in how men are screened for prostate cancer. So what can the imaging add? Again, it's overcoming these limitations of PSA-based screening, improving our sampling. And then we use the information from imaging for fusion biopsies. Your urologist or radiologist can do the biopsy in an MRI magnet. But what's exciting is using this for possible focal therapy or active surveillance, like the tip of the iceberg. Imagine we could see the whole iceberg. It's a lot easier to hit that instead of a little piece. So that's what imaging adds for us. Imaging can be indicated for patients that have recurrences. Your PSA comes back after treatment. You've had multiple negative biopsies. On the active surveillance, some of you may have had something called ASAP, or this atypical small acinar proliferation. It's a precursor to possible cancer. It's been shown that patients may have a higher chance of having cancer on a follow-up biopsy. High volume, high grade PIN is another thing which is not associated with cancer at all, but can be mistaken if it's not sampled well for a different type of cancer. And we also use imaging, what I talked about, for focal therapy. Now, if you know, most patients have a biopsy with an elevated PSA. 70% of them can be negative. Do you know how often patients go on to have another biopsy in this paradigm? Well, about 50% of the time, and it's a law of diminishing returns. So every time you have one negative biopsy, you have the next one, you have a less chance of having cancer. And why is that? That's based on our old ultrasound biopsy data, how we approach things. And I really believe it has to do with sampling and targeting. That's our big thing that we're trying to overcome for patients today. And that's what I specialize in, is the imaging for prostate cancer. This is a traditional example of a biopsy. Everyone can recognize this is the rectum in the back, this black circle right here. And on the top of the prostate, away from where our needles are typically placed, this patient has a lesion. This patient had 3 prior negative prostate biopsies. We wonder why it wasn't hit. It was directly in front of your urethra. That's where your urine comes out. So sometimes when you do a biopsy, you have a little bit of bleeding. There can be bleeding into your urethra from the biopsies around the prostate, but it bleeds more when you hit the urethra and take tissue from it. So most urologists don't want to biopsy near it because they don't want to damage that for patients. So hopefully imaging can help us steer around that to give you the best biopsy. This is just some data showing that if you have a big lesion and just do a standard ultrasound-guided biopsy, you can miss a big tumor 50% of the time if it's 0.5 cc's. That just shows and illustrates the limitations we have with our current sampling platform. That's why we moved on to using imaging for prostate cancer. But a big part of imaging is screening. But with screening, we have to stratify patients' risks. And you can use different types of nomograms, statistics to determine your probability. You can use genomics, as Dr. Badani will talk about. But in the end, I think the first step is trying to figure out where something is and how big it is before we move on to these other tests. I think this helps lay the foundation of where you can make a better decision for your care. In the past, prostate cancer looked like this. You had an elevated PSA, you were sent to a biopsy. As I said, 70% were sent back to the screening pool. Other people were diagnosed with prostate cancer, sent back to continued screening, which we call active surveillance, and others went on to treatment. What's different? Well, what's different is level 1B evidence showing that MRI before biopsy can stratify a patient's risk to the point that they can maybe avoid a biopsy. This was done in London. They're able to have every patient had an MRI, a 12-core biopsy, and a template mapping biopsy, and they reported that 27% of men could have avoided a biopsy altogether with a negative MRI. So this is really exciting because this is the first time. Then on top of that, they found it was actually cost effective. So these are the leaps that are being made. So I was really excited because this is literally in the spring of this year is the first time we had evidence that this could be a valid way to screen patients, because the standard of care always has to be met when we practice medicine. So we have to have data. It's just to do a targeted only biopsy sometimes. If you missed when you did your targeted biopsy, did the patient have the standard of care? You want to maintain the best possible options in screening for your patient. I run the trial, so when I do a trial, everyone gets a targeted biopsy and a standard biopsy, and I really believe that's the important thing, because God forbid I made a mistake during the fancy targeted biopsy. I want to make sure at least you had the best biopsy possible. But this is what's, I think, the future, and hopefully we get multi-institutional level 1A evidence, we're able to reproduce this. This will be the future. You're going to eliminate many people from biopsy that did not have to have one, because everyone understands that your PSA can be elevated due to other causes than prostate cancer. So the paradigm shifts, right? Now you can have your elevated PSA, you have a prostate MRI, it's negative, thrown back into the screening pool. But if it's not, God forbid, we have new technologies to help you have the best biopsy you possibly can have today. Doesn't matter which kind of biopsy you have. I looked at a group of patients that had prior negatives, and you can see if you're repeated 12 core, it's only about 18%. The way you change, you can improve your cancer detection rate in these groups of patients. And we find that MRI-guided biopsy outperforms the standard 12-core biopsy every single time. What's fusion? We talked about it. Essentially just overlapping two types of data sets. We use ultrasound because it's cheap and it's real time, so I can see what's going on. But the MRI is really sensitive and specific for picking up prostate cancer. And what's great about MRI, it's actually horrible at finding low-grade, low-volume disease. So indirectly, it selects out people that may be at a higher risk off the bat. This is just an example of what a fusion biopsy looks like if you guys have had one. Essentially, this is the MRI that you had before. We marked an area that was suspicious right here on the top of the prostate. But this is the real-time image on the top from the ultrasound. I'm able to take those two pieces of data, put them together, and we're able to line it up, and I'm able to put the needle almost 2 centimeters into the prostate, outside the normal region that we sampled during a standard biopsy. And then we're able to biopsy through that little green olive. And that's how we sample the top of the prostate. There's no place that we can't go with our biopsy systems we have today. And this was the same guy that had those 3 prior biopsies that I showed you in the very beginning. Just another example from a different angle. So multi-parametric MRI, what is it? It's a buzzword. Essentially, it's just a specific way we do an MRI to look at your prostate. We look at the anatomy, how things look, and that to us, it's really important to be able to get spatial resolution to find out where to go. But that's just the first step. The second part is, how do the cells move? Like Dr. Tewari talked about those growing cells, they grow slow and then they grow a little bit more. So that growing a little bit more becomes more dense. The harder it is, this is what looks at how hard it is. And we found that this does correlate with higher grade cancers. So the harder it is, the higher grade the cancer that we find. So that's one of the other sequences that we look at the prostate. Same thing, the harder it is, it actually correlates with Gleason score. If you remember the pattern, he showed very loose normal cells, then it changed over time, and this sequence is actually able to see that. The other thing is contrast. I think it's important to look how contrast moves. I use it a lot because if it has a lot of enhancement, these patients could actually maybe have focal therapy because I use the nanoparticles that get deposited within these hypervascular tumors. So where did it all end up? Well, this was our big paper from 2 years ago from the group I worked with at the NIH with Dr. Pinto. This was level 1 evidence in JAMA showing that fusion biopsy outperforms the standard 12-core biopsy. So we're really laying the foundation for an image-guided approach to prostate cancer. That's what's really exciting is now, instead of just randomly sampling the ground, we look for a spot, we find the highest risk area, and we're able to sample it. So the most common thing is, if you can see it, and you can biopsy it, why can't you treat that? And so I'm going to talk a little bit about that as I close out my talk. I'm trying to make up some time as we went through to keep other speakers on time. But focal therapy is the idea, which is investigational. Can we just treat the spot? Because all the therapies that we have today for prostate cancer do come with the risks of some side effects. Maybe some leakage of urine, maybe some erectile dysfunction. So we're hoping to develop a new therapy, and I'm working on something really special here at Mount Sinai that I'm going to tell you about. So as I said, if you can see it and you can biopsy it, why can't you just treat it? And I always make sure everyone remembers that it's investigational. I do run a phase 2 trial. So what are our options when we talk about localized prostate cancer? We go to one side, ways towards the possible problems, the incontinence, the impotence. Those are the radical treatments. Then on the other side is active surveillance, where we're following it. We run the risk of possible progression. Some people are just worried about having cancer in their body. So there's a trade-off, and we try to find the best patients for each therapy because it's individualized patient care. The guys from UCL, again, I talk about them all the time. I think they've done a great job with a lot of their prostate cancer work. But looking at focal therapy and treating specific lesions, they found that in their prostatectomy cohort, maybe 51% of the people treated could have been candidates for focal therapy. That's really exciting because maybe there's going to be a paradigm shift or like a middle way that now men, instead of having surgery, could have a focal treatment. And if they do progress, they can have surgery or radiation that's no more difficult. That's what's really exciting, is it doesn't burn any bridges. So what's changed? Why focal therapy? Again, we understand that we've overtreated and overdiagnosed people. We're able to actually see disease now, and we're using targeted biopsy to diagnose, follow patients on active surveillance. And why? People don't want the side effects of current surgical therapies. Ablation energies. There's a plethora of different types of tools to use to ablate the prostate. We haven't found the best thing. But I'm working on something I think is really special and I'm going to share with you today. A little bit of the background data. These are a lot of my friends that I've worked with over the last 7 years. John Trachtenberg was one of the early pioneers in laser ablation of the prostate. Really exciting, he did a lot of great work, but they had some recurrences in field. And that had to do with the fact that they didn't have fusion biopsy at the time. It was difficulty targeting with a magnet. So there's a learning curve, especially in these patients. But he did show if these patients had a prostatectomy afterwards, there's no more difficult and no worse outcomes. The NIH had the same trial. We did this. I helped put this together when I was at the NIH. And again, we had a couple patients with in-field recurrences. Why? Because we couldn't see that well when we first started. We tried doing this at 1.5 T in the OR with our magnet. We had to switch downstairs to the 3T to better visualize our laser fiber as well as the treatment zone. So what am I doing here? I have a single, multi-center, single-arm dose RLase therapy, phase 2, looking at the ability to ablate specific areas of prostate tissue using ultrasound and MR ultrasound fusion imaging. Who's a candidate? Pretty much This is the standard across the board for most focal therapy trials, anyone with up to Gleason 7, and 2 lesions or less, and the 12 core had the overlap. Can't have any metastatic, extraprostatic extension, or suspicion of disease outside of your prostate. So let me tell you a bit about, this is one of our first patients. He was a guy that had a biopsy, low-grade disease, underwent active surveillance, got sick after a biopsy, didn't want to come back, ended up coming to Mount Sinai to see us because we have a special biopsy system where people have a much lower infection rate than if they had a standard transrectal approach, and I'm doing a trial on that as well. But he was actually found to have higher grade disease, so he was looking for possible options, and he decided to enroll into our trial of gold nanoparticle-directed focal laser ablation of the prostate. That is a mouthful. Don't worry, I'm going to try to explain it in little pieces in a moment. This is just an example of his biopsy. The region's able to be sampled in a transperineal approach. So what's unique about us and what we're doing? The nanoparticles are able to preferentially get deposited due to leaky vessels in prostate cancer. But laser therapy itself would just burn indiscriminately anything that it touched within a certain zone. So typically energy would be given or endogenously applied and just destroy tissue. What we're doing is slightly different. With the particles that are able to be deposited, the particles actually heat up and then they burn the tissue. So they only burn tissues that they can be deposited in. So it's essentially a focal treatment that's directed directly at tumors. There's no other treatments that directly target the tumor themselves. So why has this occurred? Really interesting. This graph really helps us. At this wavelength, you see the orange line compared to blood and water, which pretty much are all made out of. There's more energy put in the, absorbed by the particle, so the particle then heats up and able to destroy the tissue. So that's what we call it ultrafocal therapy. Does that make sense? You guys are still with me? So we give them through the whole body. They circulate, they're inert, and the areas with the leaky vessels, they get deposited in. And then we use the fusion biopsy technology to guide our laser fibers to that specific area. What's interesting about laser, it only goes 4 millimeters of proton through tissue, so you have to be right around that area. But if you have other things that are normal, like you don't want to burn the urethra, there's no particles deposited in there, so it doesn't heat up and it protects it. So this is a little video of how the particles work. This is how big the particle is, and then you want to compare that to a red blood cell. See how small it is? And they're able to put this in a little bit of a solution. We inject this the day before, it circulates through our patients, and then it gets deposited in these hypervascular tumors. These hypervascular tumors are common with multiple tumors, but specifically with prostate cancer, the particles are able to be deposited within that. They don't do anything unless we excite them with a laser particle. It's not going to be sunlight. It's going to be the 810 nanometer light wavelength that comes from a laser fiber, so you're not going to go outside and get burned. But the particles are able to be deposited. So how do we work through it? We use our technology to guide and plan in 3D. Essentially, this is the blue is the urethra I don't want to hit. The yellow spot's the patient's tumor, where I'm able to direct the energy to that spot using our biopsy technology, but now for treatment. This is just an example of a video of how we place the fibers in the upper left. You can see that little line along the pink line coming in. That is the way we place each fiber into the prostate using this grid technology down here to line up each spot to be able to set up the laser application for the treatments. So that's the arrow showing you guys where we're working. Once they're there, nothing really special happens. You can't see any heat on ultrasound, so we use thermocouples to measure temperatures to make it safe and protect areas around the prostate that could be damaged. This is just a little bit of a cartoon. We're able to place the laser fiber into the tissue, and you see the gold particles absorb the laser energy, it heats up. And after the case, we're able to mark down where we put the fibers in 3D space and where we put our thermocouples and what we wanted to protect and the ablation zone. But we still don't know what happened. So this was the first case. I was a little stressed about it. We're the first place in the world to apply this technology. And 2 days later, we finally get an MRI, and we're able to see the regions from before and now is completely gone. There's no enhancement in the area of the lesion. It's gone. And actually, the patient reported that he actually pees better than he ever has in the last 20 years, so he's really happy with the results. But what's really exciting is that this targeted ablation, this is a laser fiber. See this little black circle right here? It's literally 2 millimeters from the urethra. That was turned on and did not burn anything because there's no particles there. So that's what's really exciting about the technology. If there's no particle deposition, it will not destroy any tissue. So we use only hypervascular lesions, but it's really exciting. So we haven't done just back to the treatment, looking at it, this is the enhancement. You see how it's a red circle and it's white over here. And then afterward, you see how there's no enhancement at all. This is just 48 hours, but we don't know because we didn't biopsy it. But at 3 months, the entire area shrunk, it's gone, and we do a biopsy and there's no cancer there. But here's our second patient. This was even more exciting because this patient also was on active surveillance, found to have low-grade disease. We found more cancer. We performed the treatment. As you can see, the treatment on the top area, the yellow circles, again, it goes from white to nothing. And what's even more exciting is, see that black dot on the other side where that arrow is? I stuck a laser fiber on the other side, put my foot on the pedal, nothing happens. So that's what we're trying to change, is how we approach prostate cancer. That's really exciting, that we can't damage anything that doesn't have particles in it. Because the difficulty with targeting is, if you're slightly off, you could damage something. No one wants to get their rectum damaged. And no one wants to damage someone's urethra or their sphincter so they can't hold their urine. So that's why we're working with this type of technology, and it's really exciting. In conclusion, I think imaging is changing the way we think about prostate cancer screening, fusion biopsies. Focal therapy is still investigational, but it's really exciting. Maybe it can be a middle way to stave off treatment for 5–10 years. And the nanoparticle ablation spares those non-involved areas, and we can use our imaging technology to treat and follow these patients and make sure the cancer doesn't come back. That's it for my talk. Thank you guys so much for paying attention.